So our next presenter is Dr. Reza Vejafi, and he's presenting on the treatment of orbital blowout fractures, rethinking dogma.
Okay, we have a question. 50-year-old male, status post-trauma, seen 3 days after the injury. CT scan shows an orbital floor fracture with 50% of the floor involved. He has a -2 superduction deficit and 1 millimeter vena thalamus. Which of the following would you do? 1, observe, follow up in 7 to 10 days. 2, plan floor fracture repair within 1 week of the injury. 3, plan floor fracture repair in 2 to 3 weeks. 4, observe, follow up in 1 month. 5, other. Okay, we have a variety of answers here, so this talk will be relevant. I have no financial interests or relationships to disclose. I want to thank Rich Allen and our society for asking me to speak on Subspecialty Day. So I'm going to talk to you about orbital blowout fractures, and I'm going to try to convince you to rethink dogma here. I'm going to start with a quote. This is Terry Eagleton, who's at the University of Lancaster. He's a literary professor. Deconstruction insists not that the truth is illusory, but that it is institutional. So what are our objectives today? Well, these are the numbers that we're well familiar with. And some of those were actually mentioned in that question that you had, that our residents come to us with. And my goal today is to deconstruct these numbers and tell you where they came from and have you rethink why you use them. I have 3 concessions to make. The first 2 concessions regard acute repair of orbital trauma. The whiteout blowout fracture, I will concede, it needs urgent repair within 24-48 hours. If the inferior rectus muscle is incarcerated within the fracture, you will have ischemia and shortly thereafter infarct the muscle. So this needs to go to the OR immediately. The second concession is the prolapsed globe into the sinus space. This should also proceed with urgent repair. But there's only been 24 cases of this since 1971, so take pictures when you go. The third concession is there are no randomized controlled trials prospectively examining the timing of orbital fracture repair. So until then, we will continue to rely on uncontrolled, non-randomized retro or prospective cohorts. So a little bit of background. This paper, published by one of our colleagues, Michael Bernstein, in 2002, really defined how we have treated orbital fractures for the past over 15 years. Up until this time, there was really no recommendations, and that's why this paper is so seminal. The way that Dr. Bernstein did this study was he looked at all the literature from 1983 to 2001, graded those papers, and then chose 31 of those that he felt were relevant to provide the recommendations. And so what are the recommendations? So the first involves timing. So prompt repair within 2 weeks. And the second part of this are the indications for that repair. So diplopia with positive force duction testing. A large fracture, that's where the number 50 comes into play. Significant hypoophthalmos, so the number 2 comes into play there. And progressive infraorbital hyposthesia is listed. What I would argue is since that time, there have been enough papers published regarding delayed fracture repair that we need to reevaluate these recommendations. And so I'm going to take you through that. So the number 2 of 2 weeks. Where did this come from, first of all? So this was Emory in 1972 at Wilmer, where they had performed to date the largest series of orbital fracture review. So this was, by design, the patients were brought back at 2 weeks for follow-up. And so that's where that number comes from. And if there was diplopia or positive force duction testing, they would decide whether to repair or not at that time. The other paper is from Dully in 1975 out of Moorfields. And they also said the optimum time for surgery is within 10 to 14 days of injury. A bit later, Haas also described that diplopia in primary gaze due to tissue incarceration showing no improvement over 2 weeks is less likely to resolve. So what is the problem with this? This window is too long of a delay for repair of a tightly entrapped muscle, but too soon to allow for the usual spontaneous resolution of diplopia that typically occurs in non-trapdoor fractures. So post-traumatic edema and hematoma require more time to resolve than this 2-week interval allows. And so if you look at the literature in Putterman's seminal study, which once again fell out of that window. Remember, Dr. Bernstein's study started from 1983 forward. Putterman showed that at 6 months there was no diplopia present. Nishida, more recently, said at 7 weeks there was no diplopia present. And most recently, Kasai showed it at least 6 months is needed for the diplopia to resolve. So what is the literature supporting delayed repair? Well, if you go back to Emery's original paper from Wilmer, they looked at 159 patients, and there was no difference between the incidence of enophthalmos between the surgical and non-surgical group. Half of the patients in the early repair group had persistent diplopia at 3.5 years. But this paper wasn't included in those recommendations. Putterman's seminal paper, with 57 patients, diplopia and functional gaze resolved in nearly all patients. None desired surgical correction based on their appearance. So you'll say those are old. I'll provide you with some new ones. Del Canto and colleagues did a retrospective review. 36 early repairs versus 22 delayed repairs. No significant difference between pre- and post-op diplopia between the groups. Frequency of strabismus surgery was also equivalent in both groups. Our colleagues at the Jules Stein Eye Institute also published a paper a year later. It was a retrospective review, and there was no apparent difference in surgical outcome seen between early and late surgical repair. Amrith published in 2010, similarly, no statistical difference between immediate versus delayed surgical intervention. So let's go to the number 50. Where does that come from? This is 50% of the floor. And so this comes from Dr. Haas' article in 1983. And they had an equation to calculate the size of the fracture. You notice the picture, the image here. This is based on tomography from prior to 1983. I would argue that we have improved imaging since that time. So the problem here is it's difficult to predict who will develop late enophthalmos. This is a patient of my own. That looks like 50% of the floor to me. And here she is. This is a year and a half after her injury where the primary care physician has sent her to me to consider fracture repair. There is no enophthalmos. So on top of that, there is no consensus across studies on grading scales. Are these equations and calculations being consistently performed? One would argue when there are this many equations, no one has the right answer. And in fact, there are studies out there that show that these formulas lack specificity and tend to overestimate the true defect sizes in most cases. On top of that, if you take experts in looking at these fractures, there's variable degrees in the CT measurements. So let's look at delayed repair again. Shin did a retrospective review, 852 patients in that study. 401 patients had repair, the majority of which were early, 73 delayed for enophthalmos. There was no significant difference between pre- and post-enophthalmos between the groups. Beiji put in a protocol where he said, this is how we're going to treat these patients from this point moving forward, but then he went back and retrospectively looked at those patients. There were 37 with delayed repair, 18 with incarcerated tissue, 19 with depressed floor fragments. Surgery performed at 2 or 3 months, 35 of 37 were graded as successful. Most recently, and probably most importantly, Young and colleagues published in 2018 a series of 41 patients with 44 orbits involved, where the fractures were treated conservatively and without repair. 91% showed a decrease in orbital volume, and 94% showed a decrease in fracture volume. So not only are these patients getting better clinically, but radiographically, they're improving. The other number 2. This is 2 millimeters. So where does this come from? It was a random number that was selected by Dully and colleagues in 1975. Recommended intervention for enophthalmos less than 3 millimeters. Wilkins chose the cutoff of 2 millimeters. Haas agreed. Indications for surgery greater than 2 millimeters. So there is some support of this, actually. McGlory and colleagues, back in 1984, when they did a study of normal range of exophthalmometric values for black and white individuals, no individual had more than 2 millimeters of difference between the two eyes. So the normative data there shows that you should be between 2 millimeters of your other eye, or within, excuse me. Koo more recently showed that if you show the layman that they can only recognize enophthalmos once it's 3 millimeters or more. So, but the assumption here is that all patients will want enophthalmos corrected regardless of the degree. Here's a large fracture. In reality, it's difficult to predict the patient's preference. And here's the patient at resolution. There's, I would argue that the enophthalmos is subtle here. There is some ptosis there as a result of the enophthalmos, but it's pretty subtle. So shouldn't it be the patient to determine what is aesthetically unacceptable? Silverman published this trial as an abstract. We're still waiting for the paper. I'm going to ask Dr. Schinder when he's going to publish it. It was a prospective trial. I think it's a very important study to get in our literature. Large fractures were observed for up to 6 months after injury. 37 did not develop enophthalmos of 2 millimeters or more. Of the 9 who did demonstrate enophthalmos, only half chose a delayed repair. The group out of UCSD also did a recent study, retrospective, and showed that in patients having late repair, anywhere from 7 weeks to 21 years, they were able to fix the enophthalmos without problem. So, we're one society. We're celebrating 50 years. But do we have 2 schools of thought here as far as how we approach these fractures? I would propose that we do. And hopefully I've shown you that it is reasonable to consider delayed repair for clinically significant diplopia that persists and aesthetically unacceptable enophthalmos, and let the patient decide what is aesthetically unacceptable. So in conclusion, trapdoor fracture should be addressed promptly. The literature provides more than adequate evidence for a prolonged approach to orbital fractures, allowing resolution of diplopia or development of aesthetically significant enophthalmos. Delayed surgery can achieve full restoration of functional motility and aesthetically unacceptable enophthalmos. Thank you.
Thanks, Reza.